Good afternoon and welcome back. What I'm going to talk about in the next half hour or so will be the neuropsychiatry of HD. And because Ken Barrett, who trained me in neuropsychiatry, was going to talk about 6 stories after that, so I did ask him if I can pinch the idea, and we'll stick to the 6th theme, which he kindly agreed, which is not unusual for Ken. Before I start, I thought we need to agree on what I mean by neuropsychiatry. It's just one of those words that can be interpreted differently by different people. What I mean by neuropsychiatry is how people feel, how they read other people's feelings, whether they are able to experience that feeling, the way and the speed our patients think, how they organize their thoughts, and how they process the information and make decisions accordingly. And also, under neuropsychiatry of HD, again, this is what I'm going to talk about, is obviously how people behave in response to external cues or internal cues and any changes in the environment or the circumstances around them. The ability to appreciate environmental changes, the ability to understand how other people think and consider alternative viewpoints, the way patients perceive and appraise external realities. So I know this sounds a bit complicated, but simply what I'm trying to do is try to lump neuropsychiatry and neuropsychology together, because it's very difficult to I think it's almost an oversimplification to say this patient is depressed and totally ignore the fact that they have problems with divided attention or with multitasking, or they have problems initiating tasks. And there are lots of overlap between those two areas. So the 6 questions that I am trying to address, the first bit is, why is that a big deal? Why neuropsychiatry of HD is something that we need to talk about? Second point, why is it difficult to diagnose? Which is true, and I did attend David Crawford's workshop, and he did touch on this. How could we make it worse? This is just a funny way of putting it, really, but just it's what exactly should we avoid in managing somebody with Huntington disease if we were to address the neuropsychiatric aspect? Why is it difficult to expect people to receive high standard care in a generic service? Why is that, again, an issue? Why is this something that keeps coming up in meetings and workshops? And again, I did attend Hugh Record's workshop, and this was touched on. And this is something else I pinched from Hugh from last conference. Do we actually need Huntingtonologists or a specialist team for HD? And then just a bit of summary, what are the key messages? So first of all, why is the big deal? Why do we need to talk about this? It's a very common problem in HD, but actually it may be hidden. So people may be presenting quite articulately in a clinic, and they don't have an obvious problem, as opposed to somebody with very clear motor disorder, chorea, or dystonia. You can see them at a glance. But actually, people with this particular disability, neuropsychiatric problems, may not present that badly. And you may make lots of inaccurate assumptions, especially if you're not used to managing patients with HD. The other reason it's a big deal, it's variable in nature. So it isn't something that you could predict before you see the patient. Unlike the way you are trained in medicine, you know that somebody with heart failure, you know that they will have a problem with breathing and a bit of lower limb edema or whatever. And this is also linked to the treatment. If somebody presenting with this, you give them that, they get better. But actually, the nature of those problems can be very variable, and they don't necessarily follow the course of disease. So people may go through life, as David pointed out earlier, without being depressed at all. But others may have severe depression, and it can be the most disabling, which leads to the following point, that neuropsychiatric problems in HD can be the most distressing aspect of the condition to patients and to carers. And we know that this can make the difference between a viable community treatment or having to resort to residential or institutional care. It can be genetically or pathologically related to HD. So people with depression, it's a very complicated aspect of the condition. Why people get depressed in HD? Is this because they've got HD, who wouldn't be depressed? Or is that actually an over-interpretation? And this can deprive people from effective management and treatment that is available out there. Research is telling us that actually people will be depressed many, many years before they develop, or can be depressed many years before they develop the HD motor symptoms. Actually, before even they know that they are at risk of developing HD. Biological relatives will be at a higher risk of depression as well in the absence of HD. We also know there are families where HD will be associated with depression, and other families, HD may not have such psychiatric aspect. It's whether the effect of the impact of the striatal damage and the frontostriatal circuit damage or degeneration, whether this is playing part in this or not, but it's very difficult to tell, and it's most likely that it's much more complex than any of those assumptions. Neuropsychiatric problems, as pointed out already, usually lead to loss of independence, and this is one of the most disabling aspects of the condition. Paying more attention to neuropsychiatric problems can help us identify certain areas of strength. Although it is quite, again, tempting in a medical world that we try to reduce symptoms or eliminate symptoms, sometimes what we need to identify is certain areas of strength that we work on. So although we talk about HD dementia, and this is one of the things that we unfortunately have to use as a terminology to satisfy certain aspects of the system because we're in a mental health facility or whatever, but sometimes it isn't very accurate and it isn't very helpful. People with HD, for example, may not have a huge problem in terms of episodic memory. They may not have problems in remembering certain things, and they may have more problems with what we call implicit memory or procedural memory, that everything is becoming very effortful and it causes lots of fatigue and irritability. So knowing that somebody is able to remember things, although obviously it is acknowledged that people will have some memory problems, even episodic memory, but just identifying what people can and can't do would be quite important, especially if we're able to know, for example, that people still able to judge distances and they don't have any spatial problems except when it is related to their own position in the space. For example, it can be useful in setting up a management plan effectively. Also, if we ignore neuropsychiatric problems, we may be missing one of the, or a few of the most treatable conditions, aspects of the condition. So we really need to make sure that we identify things that can be reversed, can be treated. Certain aspects are much more difficult to treat, and this is again useful to know, because when we identify areas that we can't really do much about when we treat the patient, so there isn't anything that we could do to the patient to make it better, probably there are certain things that we can do to our own expectations or the environment or education to carers. If they understand things a bit more, life could be less distressing. We have two brains in the household. One of them could be quite inflexible and quite disabled. The other one may be more flexible, and we may have to make the most of that flexibility in that other brain of the partner or the spouse. Knowing our neuropsychiatric aspects can delay the need for residential care. Second question, why is it difficult to diagnose? First of all, in psychiatry, we are used to utilizing certain international classifications. Some of us will be familiar with ICD-10 or ICD. Now we're talking about ICD-11 or DSM-4, again, or DSM-5 now. So those classifications that we use when we try to communicate to GPs and each other, we say this person suffers from a severe depressive episode with some psychotic symptoms. Strictly speaking, if we are following those classifications, all what I'm saying now is not accurate really, because one of the criteria at the bottom of the long list of the diagnostic criteria is you have to exclude organic cause. So if there is an organic problem, this wouldn't fit. In other words, we're not sure really that we are treating the same condition. If somebody has got a depressive episode, we are just calling it the same thing to make our life easier and to facilitate communication and things. But are we actually talking about the same thing? If somebody with functional depressive episode as opposed to somebody with a depressive episode in context of Huntington's, are we talking about the same thing? And subsequently, would it be the same treatment? Again, we're making that big assumption that probably, yes, it is the same thing. But the evidence is mainly coming from literature to do with non-Huntington's patients. The other point is lots of our patients really will have identified symptoms as opposed to syndromes. So we, again, tend to talk about schizophrenia or bipolar disorder. But many of our patients will only have irritability or may have some poor motivation, whether it's mood-related or cognitively related is a different matter. But just they have one symptom. They may not have any of the syndromes as we are used to label them. Again, this is something David has touched on in his workshop. Many of the symptoms of Huntington disease would overlap with some psychiatric problems. So people may have problems with their appetite. They may eat a bit too much initially. And this can overlap with the poor appetite and depression. People may have problems with sleep, concentration. So if you are using those criteria to diagnose a depressive episode, this may not be very helpful. We know that somebody is anxious or depressed the way they look, the tone of voice, facial expressions, and how they talk and the position of their body. But if this is affected by HD anyway, it's very, very difficult. So somebody came off their food and they are not very motivated. Are they depressed? We're not sure. We have to be a bit more clever than just assuming that it's depression and rushing into this diagnosis. It may be to do with problems initiating tasks. It may be to do with being overwhelmed with stimuli in a very busy nursing home or a chaotic lifestyle. So it isn't easy to make those assumptions that somebody is depressed, and we need to think of other criteria to make that diagnosis. When people have communication difficulties, this will add to the problem. So you ask somebody, I mean, how do you feel, or what do you, whether they're thinking negatively about the future? It's very difficult to say what they actually meant to say, because they may have problem communicating their feelings. They may have even problem articulating what they experience, or they may have problems experiencing certain feelings. The point before that, as I say, by definition, people with HD will have altered facial expressions, tone of voice is altered, and body posture is altered anyway, so it's difficult really to tell what is going on. As already alluded to, I think it's quite important that we understand the underlying cognitive aspect. So whether somebody is sitting there doing nothing to do with any mood changes or is to do actually with some cognitive impairment is quite important to disentangle, to be able to make the right diagnosis and give the right treatment. Sometimes we come up with hybrid disorders. So there's an interaction between some anxiety, depression, psychosis, and something else that is to do with people's difficulties in, for example, understanding other people's viewpoints, or anticipating what's going to happen next, or going somewhere and say, okay, I can visualize this. I think this is what's going to happen in a couple of hours' time. If you're not able to do that, then you may look suspicious. You may look a bit angry. You may question people's motives and may be labeled as being paranoid. There are some other examples of difficulties in making the right diagnosis. Apathy is one of the big things. Apathy, lots of people will use apathy as a synonym to depression. Oh, this person is apathetic and depressed, or apathetic, can we give them an antidepressant? Again, is apathy actually a depression? Is it a symptom that patients complain of? Or is it a symptom that we think we should help because it is causing some problems with quality of life? But the actual patient is not complaining of any particular problem. So apathy could be, arguably, maybe a sign of lack of depression. The person is not depressed, they're actually indifferent. They don't have any emotional reactivity. They're just content sitting there doing nothing. At what point should we interfere? Are we actually managing the patient? Are we doing what's best for the person, or is it just doesn't feel right, and that's why we need to? I don't have an answer, but just what I'm saying is it isn't as straightforward as one may think. Is poor motivation a sign of depression or indication of problems with lots of other things? People may lose that urge of doing things. They can't just push themselves and do things. It may be a problem with divided attention, and men in the audience may know what this is like when you have, when you do lots of multitasking, and the difference between how you do things and how perhaps your wife does things, and it's just one of the sad facts of life. And apparently there's some scientific evidence that men are not that good in when people go into the kitchen and just trying to do things, and they have everything good off the hook, and children should be out, and nobody should talk to them, and radio's off, and the wife tries to take a peek, and then this, please, I'm trying to fry an egg here. Just wives, on the other hand, probably it will be just so different, just doing everything else at the same time, writing Christmas cards and painting the ceiling. And readiness for Plan B is another thing that will probably wouldn't help our patients. When they don't have that vision, they can't see things, they can't really be prepared for any minor changes in their routine or their structure. So it's so overwhelming if they have visitors, if things changed, not going as planned. So they come across like somebody with depression, but actually it may not be that. It may be this stimulus overwhelming type state. Interpreting others' emotional expressions, this may be another issue. So they can't see how distressing this is to their wife, for example, or their husband, because they can't read those facial expressions. There is some evidence that patients with HD, for example, can't really work out certain emotions in other people's. And you could actually imagine how this can have some behavior implications as well. If you can't interpret emotion of disgust, this can affect your personal care because you can't pick up cues. If it is fear, so you may be causing lots of intimidation, but you can't pick that up. So if you're not able to interpret other people's emotional expressions, again, this may not go down well with motivation. People may be labeled as being depressed. I talked about procedural memory. So everything is becoming more and more effortful. Just driving a car in the initial stages, you have to think about everything, especially if there are some distraction. And if you're playing a piece of music, and just imagine if you're learning a new instrument. And I happen to be learning a bit of piano, and I hate Mondays because this is when I have the lesson. I can't get the thing working, and it's so effortful, no matter how hard I blow in it, but just doesn't work. Psychomotor slowness. Maybe another sign of poor motivation, but again, could overlap with depression. Effective medication, people may be lacking in motivation. It's not to do with depression, but just they are drowsy. Suicidal thoughts. Again, it's quite useful to think about suicide. It's something that we're trained to do a lot in mental health setting. But is it actually the suicide thought that makes you worried? If somebody is saying, no way, I'm going to live like this for life. If I lose my independence, I will kill myself. Again, a distinction will need to be made between comforting suicide thoughts, that people will retain some sense of control. They want to be able, at least there is that one thing I can do if things go really, really bad. And these are described by patients as being comforting. And experience will tell us that people who are saying these things may never try to make any attempts to harm themselves in the future when they become more and more disabled, perhaps to do with apathy or to do with, again, poor motivation or cognitive abilities are going. But this doesn't really, we shouldn't underestimate the significance of suicidal thoughts in a context of a depressive episode. And usually there are two peaks. One is just before the diagnosis is made, when people are at risk, they may or may not have the illness. This is a big peak. And the other peak is when people start to lose their independence. Again, labeling specific symptoms. We heard already about perseveration or some of the workshops. And obsessions. People may not have the anxiety that's associated with obsession, and they may be labeled as having OCD while they are not. Organic denial, we talk about lack of insight. Automatically, in a mental health setting, we will say that this is bad. This is something that needs to be treated. But early stages of HD, it may not necessarily be a bad thing, because people will stay a bit motivated, and it may help them not becoming depressed at early stages when they are not admitting certain problems. But actually, it could be a useful defense mechanism initially. But the trouble starts when they want to drive and they want to go back to their previous job, and they may put themselves at risk. Understanding problem behaviors. If you can't do forward thinking, can lead to passivity. If you can't understand your consequences of your actions, the consequences of your actions, you may become impulsive. We talked about some origins of self-neglect. If you're apathetic, if you have problems, there's some evidence that people with HD may have problems with their smell sensation. If you're not able to read other people's emotions, irritability, etc., this may cause problems. Apparent self-centeredness, again, people, because they can't appreciate other people's viewpoints, they may have problems understanding exactly what other people are feeling. And irritability may have lots and lots of reasons, and again, David touched on that. Okay, some points in relation to treatment. One big mistake is to make an assumption that I can do it on my own. I think having I know it sounds like cliche, but an MDT is just so central to this. We have to acknowledge that people are different. Even brothers are different. Even the same individual, different in different stages of the illness. So whatever we do now to the person may be harmful in the future. If we're treating chorea now, this wouldn't be a good idea a couple of years down the line when they become more rigid, for example. So they have different needs as well, maybe drug-related, maybe pharmacological, non-pharmacological, psychological needs, etc. I touched on that already, that it's a big mistake that we make that assumption that people will be depressed anyway. If we compare people with HD to another comparable condition like Alzheimer's disease, people with HD will still have a higher prevalence of depression. So it is quite important that we are conscious of this and make sure that treatment is offered as appropriate. Another mistake that we make is just the person is okay, not causing any problems. Let's just leave him as he is. And sometimes actually all what we need is to stop a medication, and the person become more alert or enjoying things more. We should be treating the person as opposed to the disorder. So we're not really aiming at eliminating chorea, or because this can simply give people depression or can make them slowed up even more. We need to think what is best for this particular patient. It isn't about reducing symptoms. If the person is not having problems with specific symptoms, we may need to think twice before we try and go in heroically and try to change things. We need to think environment. Again, the medical sort of training model is do things to people to get better. But sometimes just leave the person alone and then try to work on the sharp corners or the carpets or the time structure or the routines or create lists. People may not be able to initiate things, and they could do with a bit of what we call external initiation, a bit of prompting. We talked a lot about political correctness in one of the workshops, which is a great thing to talk about, and I'll touch on that in a minute as well. Sometimes just we do things based on the patient's pace, but it may not always be a good idea if the disability is around people not able to make that first move. But by providing some external initiation or some lists or structure, they may benefit tremendously from this. Although stimulating environment could be a good thing by prompting people to do things, but equally, if it is just so things are chaotic, people wouldn't be able to do anything. We need to think about this egocentric spatial deficit. People are struggling to judge the distance between themselves and other objects. They are not able to manipulate lots of stimuli at the same time, planning, organization, prioritization. So a simple environment, structured environment would be important. Talked about implicit memory already. If somebody is slowed up, we need to think, what can we do to the environment to help them without getting them overloaded with things around them? Another thing that we should be very conscious of is how we ask the question. People would benefit from simple yes and no question, offering some multiple choice cueing. Another mistake is to assume poor understanding, but actually, yes, people may have problems enunciating words or pronouncing certain words, but it doesn't automatically mean that they can't understand or they can't even form a good sentence that is grammatically and semantically correct. Yes, people will have very simple sentences usually, but it doesn't mean that they can't understand what we're talking about. They may not be able to score high in a language test for other reasons. They can't have a strategy to shift from, if you want them to list animals, for example, from wild animals to farm animals, etc. But actually, it isn't about language necessarily. Speed of processing slowed down. People with HD are entitled to have other problems. So we need to make sure that we don't put everything down to HD. We need to be patient when we talk to patients with HD because of a long list of reasons. We can't just keep pushing them and to get them to answer quickly because this is happening there. And if they are struggling, then that will be totally unfair to ask them a complex question and just expect an answer just like that. But the opposite to this is we need to be patient. And patients can't really wait much. And this is something else that it doesn't work. If we say, we need them to get to learn how to wait, it's very, very difficult. And it's a disability. So we shouldn't be pushing people to do certain things that they can't do for all sorts of reasons. Patients may not appreciate surprises because of they have problems with routine and sticking to routine and structure. So changing the routine will be a big mistake if we don't prepare them to that change well in advance, but not too well in advance to provoke anxiety. This is what I meant by political correctness. We need to make sure that we're not abusing certain big words to the detriment of the patient. We need to make sure that, yes, it should be, our service should be patient-centered, but what that exactly means. It doesn't mean that just offer something and tick the box and say, oh, patients didn't really respond. Okay, shall I whiz through those? Do I have some more time, or shall I leave it at that?
You're the boss. It's your conference.
All right. What time is Ken?
I'll give you another 5 minutes.
Okay, let's finish in 5 minutes. Colleagues in generic services would struggle. or this what it appears at times. What's happening? What's happening there then? This split between neurology and psychiatry and even genetics may not be very helpful. If somebody's got a mental health problem, they would struggle in an acute mental ward, and they would struggle in a neurology ward. Lots of reasons. People wouldn't be able to use the Mental Health Act in a different setting. Sometimes they would struggle with this. They don't have the infrastructure or the expertise. It would be some knowledge and skills issues in a generic setting that need to be addressed. And I know that HD are doing lots and lots of work on this. And there are some attitude issues as well. This is the kind of thing that you may have come across. And some training issues, how we can manage somebody with this complex cognitive makeup together with some motor changes and psychological changes as well. People in generic services, colleagues in generic services may not feel that this is something that we need to pick up. And it's just, it's a very, very rare condition, isn't it? So why should we learn about this? But again, we know now that it isn't as rare as we thought it was. Why do we need a specialist team? Because it's a complex condition. The interaction between the cognitive aspect and psychiatric aspect related to a specific change in the, like caudate atrophy will cause two things. One may be mood related and the other one is cognitive related. And it's a bit naive to say that the neurologist should manage this number of neurons and psychiatrists would do the rest. Medications that we give can affect the neurological aspects, and what we give for chorea can affect the mental health. HD teams are particularly good at appreciating that it is a family condition. We're not treating a person, we're treating the whole family, the children in the family, the carer, people who are at risk. You'll be having those slides, so I think I'll just touch on things that they're not there. We sometimes need to be brave and ask specific questions about things that we don't routinely ask, because this may be the whole thing underlying the difficulties in a home setting. Lots of needs and lots of things that we need to think about. It isn't just about the medical bit. How we can make the care plan related to a particular patient is a challenge. But again, it's difficult to do that if you're not routinely working with patients with HD. Certain things like executive dysfunction will deteriorate slower than other aspects of the cognitive divided attention or multitasking may deteriorate a bit quicker. And it's useful to understand that people may retain certain things. If we don't have evidence to support our practice, sometimes we need to think of our practice and try to generate the evidence. I think I would leave it just a couple of slides just to have those up. And the bottom one is particularly I would like to highlight that it is sometimes the HD that we need to make sure that it's HD talking. It isn't the person's. We haven't got a different person. Still, the loved person is there, but if we distangle or if we can just be able to see beneath that ugly mask of HD, things can be hugely different. Thank you very much.